Good morning, dear colleagues. I thank the scientific committee for the invitation to talk about sedation in patients with ARDS today. So sedation in this patient starts early to allow the intubation procedure and to allow a comfortable mechanical ventilation, but not that the duration of sedation is shorter than the duration of mechanical ventilation because the patient needs a time for awakening and a time for weaning from the mechanical ventilation. And the deeper and the longer the sedation will be, the longer the mechanical ventilation will be, as well as the duration of stay in ICU and hospital. So, very important things start early with the sedation that can impact up to the quality of life and survival. So, it's very important to talk about sedation. First thing to say is that not all patients need sedation. For example, these non-ARDS post-operative patients with peritonitis with septic shock, most of them don't need sedation. And an early strategy to stop sedation is associated with extubation time, but also home discharge at day 28. It's why huge efforts and guidelines have been provided for the past 20 years. And the key strategy to minimize sedation is to place analgesia management at the top priority, because analgesia first strategy is associated with the reduction in the amount of sedatives and the requirement also of paralytic agents. So, for example, this A2F bundle was tested in 25,000 patients across nearly 100 hospitals, showing a reduction of mortality, but also duration of delirium, coma, and ICU stay and hospital stay, so resource utilization. And again, the top priority is the latter A. It's to assess, prevent, and manage pain, and B, both spontaneous awakening and breathing trials to make sure that the patient doesn't need sedation or mechanical ventilation anymore. Choice of the drugs, the less associated with delirium. Avoid benzodiazepines and regularly check for the level of sedation to adjust the dose of sedatives and opioids. Delirium screening, early active mobilization, family empowerment are all intricate concepts. But the question is this kind of bundle be applied in patients with ARDS, especially the COVID? This recent study is the largest one investigated sedation and delirium in ICU COVID patients. It enrolled more than 2,000 patients in 69 ICUs, and it showed that most of patients, of ICU COVID patients, required an invasive mechanical ventilation, and most of mechanically ventilated patients were deeply sedated. Look at the median RASS level, it was -5 the first week of mechanical ventilation. Looking at the A2F bundle, assessing pain, sedation, and delirium were frequently used, but some other parts of this bundle were not. The spontaneous awakening and breathing trial were done less than 1 day out of 4. Most of patients, or half of patients, received benzodiazepines, and early mobilization and family visitation were poorly applied due to safety concerns regarding the COVID. Look at the risk to develop delirium. Benzos were associated with a higher risk, and family visitation with a lower risk. So we have both pharmacological and non-pharmacological modifiable factors. Look also at the continuous infusion of opioid which was associated with the increased risk of delirium. Note that when we said that assessing pain is the top priority, it is both to allow for an effective analgesia, but also to allow for a reduction of opioid to reach the minimal dosing. Also, non-opioid analgesics can be used instead of opioids or to reduce the dose of opioids. So the big question is, can these guidelines and concept of sedation minimization be applied in patients with ARDS? Because deep and prolonged sedation again is associated with outcomes, but also healthcare resource utilization, and this is especially relevant during the COVID pandemic because of ICU beds lacking and the risk of sedatives shortage. It is why an expert panel recently provided some guidance about analgesia and sedation. And they suggested to add a R letter to the A2F bundle, and R is for respiratory drive control, because to apply this A2F bundle and all guidelines about analgesia and sedation in mechanically ventilated patients, it is paramount to focus on the ventilator setting, because to treat asynchrony, the ventilator setting is much more effective than the increase of sedatives and or opioids. For example, look at the left part of the screen. It is a severe double stacking asynchrony in patients in assist control volume mode related to a very short inspiratory time setting. And on the right part of the screen, the inspiratory time was raised up to a physiological time of 1 second, and it suppressed the double stacking completely. But look at this second frequent kind of asynchrony, wasted effort, probably related to a low sensible inspiratory trigger or a very high patient's demand. And for another example is this double stacking asynchrony, very severe, that will be completely corrected without any wasted effort by switching to a spontaneous ventilation mode such as pressure support ventilation. But doing this, we should check for persistent high patients effort that may alter lungs and diaphragm associated with the high transpulmonary pressure. So look at the clinical exam, monitoring, and pay attention to high tidal volumes, especially with low PEEP. So it's top priority to better set the ventilator, but with an association with the control of patients' respiratory drive. And these factors include the stress-related symptoms, pain, anxiety, dyspnea, as well as the physiological factors, fever, metabolic acidosis, hypercapnia. And to manage this, we could propose non-pharmacological intervention, and the ventilator setting is one of these non-pharmacological intervention. It can reduce anxiety and dyspnea, multimodal analgesia with non-opioids, and in last step only, use or increase the opioid sedatives or use paralytic agents. Consider intermittent ordering before continuous infusion to spare these drugs. So if you need to sedate the patient, which level and which drugs? The level of sedation, one size doesn't fit all. We could suggest a progressive three-tier strategy according to patient ventilator asynchrony, along with usual guidelines. About the drugs, avoid benzodiazepines, propofol or dexmedetomidine, but mind that dex cannot be used for deep sedation because of hemodynamic instability. Also note that we still need benzodiazepines in critical illness. In the patients with the most severe hemodynamic instability, the benzodiazepines are still indicated because these are the most robust sedatives if sedation is required. And in patients difficult to sedate, we could consider anesthetic gas or in case of risk of delayed awakening. Indeed, halogenated gases are always effective to sedate the patient, and they might be associated with an improved gas exchange and lung injury, this needing to be confirmed by an ongoing multicenter randomized controlled trial. When you use anesthetic gases, meant to avoid any leak. For example, the exit of this gas analyzer is connected to the expiratory filter of the ventilator to avoid any leak that could contaminate the atmosphere. It is important for all patients and especially in case of COVID. So two remaining big questions. When considering lightning sedation in ARDS, day one, very severe ARDS, probably not today. We have to improve the respiratory condition of this patient. So as soon as there's an improvement stabilization of the PF ratio above the 100-150, we could ask this question and try to reduce sedation. Sometimes it works, sometimes it doesn't. There will be a second attempt later, but we have to ask this question, otherwise all the patients will be sedated and ventilated very deeply for 1 week. And some patients can be awakened early, and we have to try it. Second question, how to assure comfort if paralytic agents are used? The guidelines said we need to assure analgesia and sedation before paralysis, then regularly stop the paralytic agents to make sure that the patient is comfortable and sedated. No recommendation today about neuromonitoring. And mind that when we use a bispectral index, 10% of patients will be awake or even agitated just after paralysis recovery, even if their bispectral values were under the 60. So when we use a bispectral index in paralyzed patients, it's to check for any awakening and to increase the sedatives and opioids, but not to reduce these drugs. We still need today paralysis window to make sure that there's a comfortable patient. New monitoring such as heart rate variability and analgesia nociception index. You can see on the low boxes that the ANI is more sensible than the bispectral index up boxes to detect pain, whatever the paralysis condition, left boxes during paralysis and right boxes just after recovering from paralysis. Donc more sensible and more reliable than the bispectral index. In conclusion, analgesia and sedation are still challenging in patients with ARDS. The acute phase needs often deep sedation and even often paralysis. And the comfort assessment is still a black box. We still need frequent paralysis windows to make sure that the patient is comfortable and sedated. Then we have to assess as soon as possible if sedation can be lightened, because deep and prolonged sedation, again, is associated with patient outcomes as well as healthcare resources, and this is very relevant during the COVID pandemic. To do that, lightning sedation, the top priority is to manage patient respiratory drive. We have to treat fever and metabolic acidosis before lightning sedation. And also we have to check pain, anxiety, and dyspnea to treat this, optimizing ventilator setting first before increasing sedatives and opioids, using early spontaneous breathing mode, but along with screening for high patients effort that could impair also the respiratory mechanics. So thank you very much for your attention, and good luck with managing your patients, especially during this COVID pandemic. Bye-bye.